Good afternoon, everyone. My name is Ioana Anguranu, and I'm a Community Health and Prevention Analyst at ASTO. ASTO is a national nonprofit organization representing state public health agencies in the United States, the U.S. territories, and the District of Columbia. I'm honored to welcome you to this webinar on behalf of the CDC. Today, we will highlight research and programs prevention research centers have developed to increase protective factors and prevent risky behavior among adolescents. This webinar is a third of a three-part series highlighting research and tools developed by Prevention Research Centers. The Prevention Research Centers program consists of 26 public health universities or schools of medicine that conduct community-engaged research. Each PRC designs, evaluates, and implements health promotion and disease prevention programs that reduce health disparities. PRCs conduct research and develop tools for a variety of public health topics, including smoking and substance abuse, cancer, cardiovascular disease, injury prevention, sexual health, adolescent health, obesity, nutrition, and physical activity. Today, we will highlight adolescent health research developed at the Healthy Youth Development Prevention Research Center at the University of Minnesota and the Center for Healthy Communities Prevention Research Center at the Oregon Health and Science University. As will be featured during this webinar, Prevention Research Centers engage community stakeholders and state and tribal public health agencies in the implementation of programs. In addition, Prevention Research Centers offer technical assistance to public health agencies through policy evaluation and program development. The ASTO President's Challenge is a yearly initiative to improve population health. The 2017 President's Challenge, led by Dave Butler, the Director of Public Health at the Alaska Department of Health and Social Services, focuses on proven public health approaches to prevent substance misuse and addictions. As seen in the President's Challenge Prevention Framework, a key strategy to prevent substance misuse is to increase protective factors and reduce risk factors in communities. Increasing protective factors and building resilience are key components which prevent behavior such as substance misuse for adolescents. Our goals for this webinar are to describe how prevention research centers and other affiliated partners evaluate and develop policies and programs that build resilience for youth and reduce risky behavior. Today, presenters from two prevention research centers will describe the implementation and evaluation of two adolescent health programs. Presenters at the Healthy Youth Development Prevention Research Center will describe the importance of increasing protective factors for youth and how state health departments can include protective factor measures in youth behavior surveillance systems. Our presenters will also discuss how health agencies can partner with educational and community partners to increase protective factors, such as educational connectedness. Lastly, presenters from the Center for Healthy Communities and Northwest Portland Area Indian Health Board will provide strategies for collaborating with tribal health agencies to reduce health disparities for Native American youth. Before we get started, I would like to provide an overview for the logistics for this afternoon's webinar. This webinar is currently being recorded, and a link to the webinar and webinar slides will be sent to you via email. Following each presentation, participants will have the opportunity to ask presenters questions. We invite you to participate by typing your questions into the on-screen chat box at any time during this webinar. If you are having technical difficulties, please let us know through chat. Our first presenters are Dr. Renee Zaving and Dr. Jennifer Oliphant, who will discuss the implementation of Partnering for Healthy Student Outcomes, a two-part program that increases educational attainment and reduces risk behavior through in-class evidence-based social-emotional learning and teacher professional development. Renee Zaving is the Director of the Healthy Youth Development Prevention Research Center at the University of Minnesota. Dr. Zaving's research focuses on understanding influences that help adolescents avoid risky sexual behaviors, violence, and early pregnancy, and on testing interventions that involve health clinics, schools, families, and communities in promoting young people's health and well-being. Jenny Oliphant is the Community Outreach Coordinator for the Healthy Youth Development Prevention Research Center at the University of Minnesota. In this role, she assists communities in developing and implementing best practice public health approaches to adolescent health issues. Her expertise areas include sexual health, youth development, and sports education.
Hello, everyone. This is Renee Zaving from the University of Minnesota. It is such an honor to be able to speak with you all. In the first segment of today's webinar, Jenny Oliphant and I are going to describe some of the conceptual foundation, really, for our work. as a prevention research center. We're also going to provide you with some examples of ways that we collaborate with state health departments, and we'll highlight sort of our current core research study, which focuses on middle school youth and teachers. Before we get started, it's really helpful for us as presenters, both from Minnesota and Oregon, to get to know you a little bit as an audience. So I'm hoping that you would take a minute to answer this poll question. And the question is on your screen: what % of your work has an adolescent health focus? That would include managing staff and or grants. So if you could take a minute and give us your input, we'd appreciate it. Super. And so the responses are coming in, and looks like we have a sort of a split across categories, with some folks that are on the call having, maybe a quarter of their activities involving adolescent health, and then others on the call, about a third of folks on the call saying that at least 3/4 of what they do has an adolescent health focus. It's useful background for us, and I hope that the information that we share and our colleagues from Oregon share around adolescent health will be useful to you in your work. So the mission of our Prevention Research Center at the University of Minnesota is to partner with state and local organizations and communities to conduct research, to provide training, and to disseminate best practices in advancing health equity and promoting youth health and positive youth development. In other words, we work with state and local partners to develop, to test, to implement, and to evaluate programs, practices, and policies to promote healthy development and to prevent negative social and health outcomes among adolescents. Okay, so one additional poll question for you, just to give me a sense of your familiarity with the phrase positive youth development. So that phrase, and you can choose the response that seems best to you. Does that phrase refer to a natural process, a set of principles, or an advertising campaign? Excellent. So as I'm seeing your responses come in, I see that the great majority of you think about positive youth development as either a natural process or a set of principles, and really both of those aspects are true of positive youth development. It's both a natural process of development, and then a sort of core set of intentional principles that can guide programs, practice, and policy. I wish it were an advertising campaign, but as far as I know, it's not. So at the University of Minnesota Prevention Research Center, our research, our training, and our dissemination efforts are guided by several core concepts that you see on this slide, including the concept of healthy youth development, or also known as positive youth development. Grounded in a view that adolescents are resources to be developed rather than problems to be fixed, we define positive youth development as intentional processes of providing young people with the supports, the relationships, the experiences, the resources, and the opportunities they need to thrive and to become competent adults and contributing members of their. Our work at the Prevention Research Center in Minnesota also has an orientation in resilience, or the processes by which individuals may demonstrate positive health and social outcomes despite being exposed to substantial adversity in their life. The key to both healthy youth development and resilience is the concept of protective factors that can help young people avoid negative effects of risks such as pervasive poverty in a community or parental mental illness, and also help them to avoid some of the risky health behaviors that we know are threats to their health, such as early substance use and abuse. So protective factors can include both internal assets and external supports. Internal assets are those factors that reside within individuals themselves, such as skills and competencies, a sense of self-confidence and self-efficacy. External resources really also help young people overcome risk, but they're external to individual young people. Such resources may include parental support, adult mentoring, and youth-friendly community services. So there's really a large body of research that shows that increasing these protective factors in young people's lives, in other words, building adolescent skills and self-confidence, enhancing their connectedness to family, to school, and to their communities, reduces the likelihood that they'll engage in a number of health-jeopardizing behaviors. So please now allow me to share several of examples of how we collaborate with our colleagues in state health departments on research, training, and dissemination of best practices in adolescent health and positive youth development. The first is just an example of a collaboration that we have with the Minnesota Department of Health around research. So the Minnesota Student Survey is a survey that was begun in our state in 1989. It's really one of the longest running youth surveillance surveys in the nation. Every 3 years, the MSS, as I'll call it for short, is administered to 5th, 8th, 9th, and 11th grade students in public schools, charter schools, and private schools throughout the state. The Minnesota Student Survey includes questions on both health risks and protective factors. So specific topics include tobacco, alcohol, and drug use, questions on school climate, physical activity, violence, and safety, questions on connections with school and family. In 2016, which was the last year that MSS was administered, we had about 282 of 330 school districts in the state. That's about 85% of districts, and nearly 170,000 students from Minnesota participate in this survey. Our Prevention Research Center and the Division of Adolescent Health, which we are housed in, have been long-standing partners to Minnesota Department of Health and other state-level agencies that administer this survey. At several points since 1989, Minnesota legislatures, the state legislators, have called into question Minnesota Student Survey's use of passive parent consent procedures. And in response to those challenges, our faculty and our researchers have provided testimony to legislatures on the scientific trade-offs with the use of active versus passive consent. The Department of Health really turns to our PRC when they're identifying a need to revise questions and items that are included in this statewide surveillance instrument. For example, in 2013, Minnesota Department of Health decided to add questions about students' internal assets to this large surveillance questionnaire. And so they came to our PRC and asked our researchers to identify existing multi-item scales that measured youth assets. We were able to discuss a range of existing scales with them, and they then selected one of those scales to use to measure internal assets of students completing the MSS. Likewise, it's a two-way street. When researchers that are affiliated with our PRCs see the need for statewide measurement of important adolescent health constructs, we contact the Department of Health and ask them to consider adding key items. For example, in the 2013 Minnesota Student Survey, a PRC researcher worked closely with the Department of Health to add an item assessing kind of the prevalence of parental incarceration among students completing the MSS. And then finally, MDH relies on adolescent health researchers at the University of Minnesota to conduct sophisticated analyses with this large statewide data set. And our researchers deliver. We have an MSS working group at the university, including faculty, staff, and fellows, that meets twice a month to discuss ideas, share analyses that of the MSS data that are in progress, and to generally encourage each other and spur each other on. To date, we've published around 20 manuscripts from the 2013 MSS data, and we have also used this statewide data set as the basis for 3 of our active federal research grants that combine this broad statewide surveillance data with other data sources to look at and analyze some of the social determinants of the health of adolescents in our state. So moving into sort of a second example of our collaboration with state health departments, this example really is in line with our goal of working with state-level partners to expand the capacity of professionals and organizations to implement best practices in adolescent health. Specifically, we provide training on a variety of evidence-based teen pregnancy, STD, and HIV prevention programs. We offer training on both sexuality education curricula and youth development programs. Our trainings, which are highly interactive, include practice in skills of teaching and opportunities for those being trained to teach activities in the curriculum to others at the training and receive feedback on their teaching. As a complement to the trainings we offer, we also provide customized technical assistance to groups to support them in selecting appropriate programs for their population and implementing those programs and evaluating them within the group of young people that they serve. And so we have several state health departments, including Minnesota, the Arizona Department of Health, and the Oklahoma State Health Department that have federal funding to implement sexuality education throughout their state or in specific regions of the state. And with all of these health departments, we partner and train their grantees, maybe at a regional level, a county level, or a local level, that are preparing to implement evidence-based programs related to teen pregnancy, STD, and HIV prevention. Our Prevention Research Center also works with state health departments to disseminate and translate adolescent health research into policy, programs, and practice. A clear example of this is our work with the STD and HIV section of the Minnesota Health Department. In Minnesota, as in many of your states, chlamydia is a leading cause of morbidity, and it disproportionately affects adolescents and young adults. Almost a decade ago, the Minnesota Department of Health launched a statewide initiative to increase awareness of chlamydia's impact on young people in our state. The PRC was a lead participant in forming the Department of Health's Minnesota Chlamydia Partnership, which was really an innovative statewide approach to eliminating chlamydia among our young people. In addition to the Department of Health and the PRC, that chlamydia partnership includes Minnesota's largest health plans, as well as clinics and local public health organizations, all focused on improving awareness, as well as improving screening, testing, and treatment of chlamydia. In 2011, the partnership released the Minnesota Chlamydia Strategy, which really was a statewide action plan to reduce and prevent chlamydia that is grounded in the ecological model that you see on this slide. And then in step with that, in 2012, our PRC developed a user-friendly special report, and you'll see the cover page illustrated on this, also illustrated on this slide. And this special report articulates some of the action plan's key strategies in short and visually appealing publication that's really intended for general audiences. So following the release of the statewide action plan and the special report on chlamydia, our PRC continued to provide technical assistance to the chlamydia partnership. Specifically, we work with county and local public health agencies throughout Minnesota who are implementing non-traditional approaches to preventing and control of chlamydia that have been outlined in the statewide action plan. So with that, those examples of ways that we work with public health departments and specifically with state health departments, I'm going to turn the microphone over to my colleague, Jenny Oliphant, who's going to talk a little bit with you about our core research study, Partnering for Healthy Student Outcomes.
Thank you very much. This is Jenny Oliphant, and I'm really pleased to join you this afternoon and hope that you're finding each one of these slides and your time in this webinar very useful. I'm excited to be talking about our core intervention project, which is, as Renee Sieving suggested, is called Partnering for Healthy Student Outcomes. We are looking in this intervention to both improve the health and the academic outcomes for middle school students, a group of young people who are often neglected in terms of thinking about social and emotional health, especially in the United States where young people are often thought of as problems rather than resources, as Renee indicated. Our Partnering for Healthy Student Outcomes is a multi-dimensioned intervention. It starts with a curriculum that is an evidence-based curriculum focused on social and emotional learning. This evidence-based curriculum that we have selected for this middle school intervention is called Lion's Quest. The Prevention Research Center is using this because it is listed on many social emotional websites as a program that works or with high potential. It has some core topics. These are not necessarily only specific to Lion's Quest, but are often found in other evidence-based curriculum for social and emotional learning. The core topics that we're focusing on here are connection to school. We're also looking at positive behaviors, focusing for young people on how they can resist bullying pressures as well as stop them and not participate in them. The curriculum also has relationship skill building and discusses self-awareness and then dealing with anger and frustration. Our lessons are in the classroom in and of themselves. The classrooms are generally a homeroom-like situation. In a middle school model, those are often called advisory. The lessons are short. They're meant to be about 20 minutes long. Sometimes they can be a little bit longer, sometimes a little bit shorter. Each one of our classrooms in the schools that are participating teach the Lion's Quest social emotional learning 1 or 2 times a week. They are meant to be very fun, they're meant to be very interactive, and also they are meant to be very reflective. One of the key aspects that you will see in social and emotional learning curricula is that they generally have a reflective element. They also also key part of these is that any SEL curriculum, social emotional learning curriculum that is adopted really must be teacher friendly. Teachers are so busy and aren't interested in adopting things that they yet have to learn or do a lot of manipulation to. So this is one of the reasons we have selected Lions Quest. In addition to this, the curriculum itself, which the PRC, as I said, did not develop, but is using, the Prevention Research Center here at Minnesota does provide some coaching and support for the implementation. Being a very user-friendly piece, though, that actually is quite minimal in what we must do in order to keep it running. There's a second aspect of our Partnering for Healthy Student Outcomes, and this is a classroom-based social-emotional, or in addition to the classroom-based social-emotional learning, it's a teacher training or preparation program. This is a professional development aspect of the curriculum, and in this aspect, teachers are guided through a traditional coaching methodology to increase their capacity to be strong learners of how to engage young people. As you can see here on the screen, the core topics that are addressed in the professional development are relationship building. So again, going back to that connecting to young people, wanting to get to know the young people better in their classes beyond just being a student in their room. They also work on, as teachers, their communication styles and how they interact with young people, as well as their classroom and time management and then engagement for instruction. There is quite an extensive model in this process, and so the implementation focuses on multi-dimensional areas with many touch points to the teachers. This piece has an initial training and a booster session. Then we also have some relationship-based coaching where there's a plan for greater student engagement with the teacher, for the teacher. That is teacher-driven. It is not driven by the coaching staff that is helping the teachers. We also have a very extensive classroom observation model where we give feedback to the teachers and not the administrators, an important aspect of this. But we give feedback to the teachers on their styles and what is working and what yet still needs work. And then overall, and a very important aspect of both social emotional learning curricula as well as the Partnering for Healthy Student Outcomes teacher implementation aspect, is that the whole school needs to be addressed. This is an environmental context in which things happen with young people, and addressing not just the teachers and not just the students, but the entire environment is exceedingly important. We are in the process of evaluating this, and so we are looking at health risk behaviors such as bullying, violence prevention, and substance use. And we are also measuring whether we get greater student engagement, better attendance, academic achievement, and school completion. This is a 3-year program, so we don't yet have the outcomes of these, but we are very, very hopeful and quite pleased with what we've seen so far. It's very, very important that these curricula and that these interventions really focus on the most disengaged learners, which is often actually what isn't usually done with young people. And in fact, we see a lot of young people that are very disengaged are actually set aside, and often in some school districts simply transferred out. That is not what we're looking for in this. we wanted to provide you with additional opportunity to connect with us. And on our screen here, you can see the different aspects involved in the studies. And if you would like to reach out to us, we would be more than welcome to have a longer conversation with you about any of the projects that we are working on. I'd like to thank you for this aspect, and we're going to send it on to our next colleagues on the call.
And we have time for maybe one or two questions. I just have a quick question for everybody. Do you have any recommendations for states or other health agencies who are thinking of implementing a similar program?
I would say that for any state or health agency that is interested in implementing a program, a lot of coordination is very important, as well as working with the state health department to look at what they are already doing, and in addition to their State Department of Education. Wonderful research that we often refer to as well is CASEL, which is an organization that focuses on social emotional learning for young people and has a list of programs that have high promise or have been evaluated to work.
And CASEL is the Center for Applied Social and Emotional Learning. It's a great resource of evidence-based social emotional learning programs that would allow states and communities and local school districts to find an evidence-based social emotional learning program that really fits with their student population and their needs.
Great. Thank you so much for your presentation. The second presentation will feature Dr. Bill Lambert and Dr. Michelle Singer from the Oregon Health and Science University Center for Healthy Communities and Dr. Stephanie Craig Rushing from Northwest Portland Area Indian Health Board. They will discuss the implementation of Native Students Against Negative Decisions, known as STAND. Dr. Bill Lambert is the Associate Director of the Center for Healthy Communities at the Oregon Health and Science University Center and is the co-principal investigator for the Native STAND Dissemination, Implementation, and Evaluation Project. Dr. Lambert has worked with tribal communities for over 25 years on various public health and environmental science issues. Michelle Singer is a tribal citizen of the Navajo Nation and is the project manager of the Oregon Prevention Research Center Core Research Project Native STAND. Michelle has contributed to health education, public policy, and community engagement in Indian country for over 25 years. Stephanie Craig Rushing is a project director at the Northwest Portland Area Indian Health Board. She contributes to mixed method community-based participatory research activities at the regional and national level, designing multimedia health resources for Native teens and young adults. Please go ahead and start your presentation.
Thank you, Ioana. Good afternoon, everyone. It's a pleasure for us to share our research with you. Michelle, Stephanie, and I thank you for joining us on this call. As many of you are aware, Native people are wary of joining in research and very careful when entering into partnerships with universities and outside agencies. The sense of caution comes from a long history of oppression and loss and the commitment to protect culture and tradition. With research or the delivery of any public health program, certainly communities remember past abuses, and communities have seen a lot of so-called helicopter research where outsiders come in, deliver a program, collect their data, and leave without any long-term commitment to communities or any sharing of data. While outsiders may have the highest intentions of goodwill and assistance, I believe in my experience that they must recognize and respect the American Indian and Alaska Native communities as sovereign nations with the right to self-governance and self-determination. Therefore, the partnerships must be carefully and patiently entered into. Certainly, the tribes see their primary relationship, government to government, with the federal government under its federal trust responsibility. But more and more, states are entering into agreements with tribes, And in many ways, these agreements are not unlike the kinds of agreements that we've entered into as a university to work with tribal communities here in the Pacific Northwest and around the country. We follow principles of community-based participatory research, and in this approach, we work with tribal community scientists shoulder to shoulder, and actually together we set the research agenda, we do problem assessment, develop the intervention program or policy together, and we evaluate it together, and this assures its delivery and maintenance and has the added benefit of making the intervention relevant and durable in communities over time. Sometimes as we enter into research, we tend to focus on the standard human subjects protections of respect for individuals, beneficence, and justice, but it's also important, particularly in working with tribal communities, to commit to a principle of respect for communities. The research programs that you'll hear us present on have been reviewed and approved by tribal institutional review boards, and in addition, we've established data sharing agreements with our tribal partners, recognizing that the data belong to our tribal partners. The challenges faced by all youth today are many, and they're particularly challenging for tribal youth. I think all youth in today's world of mass media, social media, entertainment, and advertising are bombarded with conflicting messages on sexuality and relationships. And I think the challenges faced by today's Native youth are huge and include a lengthy list. Here are the risky behaviors that our interventions address. They're not unlike those you heard described by the University of Minnesota, PRC. In particular, in our programs, we focus on teen pregnancy, STIs, and HIV, but we're also concerned about suicide and substance abuse. Certainly, Native youth behavior is influenced by an array of social and ecologic factors, including high levels of poverty and substance use, insufficient sex education, poor access to reproductive health services. There's also stigma, social violence, and historical trauma. Generally, we're seeing teen pregnancy and childbearing impacting Native youth disproportionately compared to white youth, and in ways similar to other communities of color. STIs and HIV among Native youth are also a serious public health problem, and all of these outcomes adversely impact economics for the communities, but most importantly, these adolescents' future lives. When we look at youth risk behavior surveillance data for Native high school students, we see they're more likely than white students to have ever had sex and to have been tested for HIV. And with preventive behaviors like condom use, we see they're similar to other racial and ethnic groups, probably running around 50 to 60%. All the levels of risky behavior that we're familiar with and those measured directly in communities that we're working with indicate the need for more effective programs to help these youth and to help them make responsible decisions. Our communities are very aware of these challenges that their youth face. And they also are aware that their teens are living in two worlds at once, one with traditional culture and values which provide many strengths and resiliency, and also a world of the dominant society, as I mentioned, with a lot of input which comes from mass media, social media, and outside influences. The challenge for us that we faced in terms of assessing readiness is to move community leaders beyond simple recognition of the problem towards programs of action and to commit capacity within their community to work with the evidence-based intervention and best practices to keep them going. Our program, Native Stand, as we describe it today, is one where we're actually measuring the uptake, adaptation, and maintenance over time of a promising intervention. Our major community partner in this research work and public health intervention is the Northwest Portland Area Indian Health Board. And the website information is on this slide for you. And you can see here that they represent the 43 federally recognized tribes in Idaho, Washington State, and Oregon. Our mission, together with them, is to partner to bring healthy practices to youth, but in a broader sense, to all groups across the lifespan to improve and reduce chronic health conditions. Our Center for Healthy Communities is located near the Portland Area Indian Health Board, and its website address is located here. Our Prevention Research Center works on a variety of research projects and training programs beyond Native Stand, which is featured today. Other things that we do and are listed on this slide and include the Summer Research Training Institute for American Indian and Alaska Native health professionals. And now as we speak, hundreds of young professionals are being trained in health sciences research methods and program evaluation and delivery in Portland. We've also worked in the area of prevention of hearing loss and vision loss, cancer prevention. We are a participant in the Healthy Brain Research Network, dental and oral health, and also other injury prevention programs, notably the Native Children Always Ride Safe, or CARS, dissemination project.
Thank you, Dr. Lambert. This is Michelle Singer from Portland, Oregon. I'm Navajo, and I just want to introduce myself in my language. Michelle Singer, thank you so much for this opportunity. I have the great honor and good fortune to work with Dr. Craig Rushing and Dr. Bill Lambert as the program manager of Native Stand. It's our core research project for the Oregon Prevention Research Center. And as you see, Native Stand is a culturally relevant, healthy decisions curriculum for enhancing and promoting positive Native youth development and well-being. The intertribal curriculum is an evidence-based intervention for high school age Native students, incorporating tradition and culture to address sexual health. Our center project is to recruit and train and support 50 American Indian and Alaska Native health educators to implement Native Stand and evaluate its adoption and impact in their communities. As Dr. Lambert had mentioned, again, we do see our communities wanting to address these issues that are happening amongst high school age youth. And what we do is we teach the Native Stand curriculum to health facilitators who discuss the curriculum or learn the curriculum. As you see here, there's 3 manuals, which is online at OregonPRC.org. It's a decision-making curriculum that has a variety of interactive discussions and activities that promote diversity, self-esteem, goals and values, team building, negotiation, refusal skills, just to name a few. It's a curriculum that contains stories from tribal communities intertribal that have ground learning and cultural traditions. So again, it's culturally appropriate as well as culturally sensitive. The curriculum is flexible and can be easily adapted to include specific stories and traditions from the local community in which it is used. Some of the evaluation from Native Stand that has been validated in 4 Bureau of Indian Education schools and 1 reservation community demonstrated that teens demonstrated significant and consistent improvements in knowledge of STD, HIV prevention, reproductive health, and healthy relationships. Teens also reported sharing information they learned in the class with other teens. Adults who facilitated the curriculum learned strategies to better communicate with teens and teach sensitive health topics. And one notable is that school staff and administrators felt that Native Stand was addressing critical gaps in their sexual health education teachings in their school setting. As you can see with this slide, it has a variety of topics. It's very flexible. The 27 sessions can range anywhere from 60 to 90 minutes. It can be very flexible in the setting and where it's taught, whether it's in schools, in boarding schools, after school, boys and girls clubs. It has been very successful and effective for our educators and our communities who have implemented in their communities. And it's an also wonderful opportunity for tribes or tribal organizations in urban settings to partner or coordinate or leverage with other programs in their community, whether it's in a tribal community or a nearby city or location where it can expand the attendance of students to have this access to this wonderful program.
So in closing today, this is Stephanie Craig Rushing, and I just wanted to share a resource that we have been working on in collaboration with OHSU's Prevention Research Center. We know that to be effective, health curricula must be age appropriate, culturally relevant, and reflect the values and learning styles of the learners being taught, and that finding curricula that meet these requirements for American Indian, Alaska Native youth can be really challenging. Different tribal organizations and tribal epicenters, universities have been working on adapting and evaluating such programs over the last 2 decades, but there really wasn't a central place for health educators or parents to go in order to access those materials. So we've been working collaboratively with a work group across different federal agencies and tribal organizations to design a website that could help teachers and educators do just that, access culturally relevant programs. It's kind of a one-stop shop. So the Healthy Native Youth website launched in August. It's pretty new. We're very proud of the work that has gone into it. The goal of the website is to provide health educators and teachers with age-appropriate, culturally tailored health resources for Native youth, to include tools that will prepare tribal health educators and teachers to deliver the content, and for us as public health people to be able to measure the reach and impact of our efforts, determining how many youth are being exposed to each program. So from the curriculum tab, you can kind of see a list. I'm actually going to go back here. I got a little excited. Of different programs that have been uploaded to the website. And you could click on the program to learn more about it. And each curriculum includes information, lesson plans, handouts, any supplemental materials that would be needed for implementation. Many of the programs include recorded videos or webinars that will prepare a facilitator to implement the program. And we also provide background information on how the program was designed or adapted and evaluated with Native youth. So, for example, the most recent program added to the website is the Healing of the Canoe curriculum, and it is a culturally grounded life skills curriculum for Native youth that focuses on suicide prevention and substance use. And it was designed to be adapted by communities using community-specific traditions and beliefs. So many of the programs included on this site can be further adapted and customized, just like Healing of the Canoe and Native Stand, as Michelle was mentioning. You can also search and filter your criteria by age group that you're looking to educate, or LGBT inclusivity, the program setting that you're planning to implement in, if it needs to be a classroom-based or after-school program. And many funding streams require organizations to use programs that meet a particular threshold for effectiveness, and you can search by those criteria as well. So we are really excited to partner with you, hopefully, to help disseminate the program. We've had about 15,000 page views since its launch from 48 states and 41 countries. And right now, the curricula, or the website has 7 health curricula in it, but we are able to add other programs if you know of other curricula to add to the website. And we really look to partner with both school systems and state health departments to help distribute these resources to communities in across the U.S. And these are the ways you can connect with us to help do that, or follow up with an email, and I can connect you to promotional materials or other resources to share with your network to help promote the website.
And I'd like to also add, this is Michelle again, the Native Stand project and program can be found at the Center for Healthy Communities, OregonPRC.org. We can also be accessed through the Healthy Native Youth website as well. But we do have a Native Stand Center for Healthy Communities Facebook page. We hope you like us. And we do share stories from the field, opportunities, things that are happening in real time with our current cohorts. Currently we have right now 2 cohorts totaling 30 sites that are in various phases of implementation of the curriculum in their communities. And we're looking forward to bringing 20 sites here to Portland in 2 weeks as a part of our Summer Research Training Institute. But we're excited of the opportunities of partnering with the Northwest Portland Area Indian Health Board and OHSU, and as a unique but also a wonderful practice to show how mainstream and Native communities can work together in both public health, eliminating health disparities, but also culturally appropriate curricula, bringing together the knowledge of both indigenous ways of knowing, but also scientific rigor. So we thank you for this opportunity.
Thank you so much for your presentation. Participants, if you have any questions for the presenters, please provide them through the chat. I just have one question to start off with. What are some key challenges you have encountered while working with tribal communities now, and how have you been able to overcome that? And are there any recommendations you have for state health agencies that are just beginning to form relationships with tribal stakeholders?
Hello, this is Michelle. I will also defer to my colleague, but just really simply, as Dr. Lambert laid out, again, there is very much all things are rooted in relationships. So certainly starting out, making introductions, outreach, coming out to the community and getting to know the site or the community, doing your homework on who your audience is, and then also the encouragement of tribal people getting to know who you are and fostering in that relationship over time to do it, working together as equals as opposed to kind of talking down to one another. Language and presentation is very important. So I would say, again, relationship building is very important.
Hi, this is Bill Lambert. I would say some of the key challenges, very briefly, are related to resources and changing conditions and needs in the communities. So I would say that in our experience, Native communities are not like any other. Are much like any other, rather, in that they have a variety of competing needs, and although they may be very committed to work on the problem that is of interest to a state agency, the other competing needs may require from time to time pulling back on that commitment and focusing on other things that are very important in the moment in the community. Being committed, as Michelle said, to work over the long term and to follow through is essential. And even though the pace of the work may slow down at times, and there are funding pressures often, still stay there, still work with your partner, communicate honestly about the funding concerns, and usually a way forward comes about.
Can we discuss some of the steps that were taken to develop data sharing agreements?
Yes. The data sharing agreement was developed with the 43 member tribes of the Northwest Portland area Indian Health Board. Discussions with the board and its Tribal Epidemiology Center occurred over many months with working groups, and together they put together a set of working principles where participation in any research is conducted under a memorandum of agreement, essentially a contract, so that the communities have full right to all the data and are viewed as owners of the data. They also have opportunity for review and comment of data presentations before it's released out in, say, a peer-reviewed journal or in a public presentation. The way that this agreement works is largely run through the Portland area Indian Health Services IRB, and when we conduct research with communities, it is the IRB that acts as the overseer and has authority to make sure that that both partners meet their obligations under the data sharing agreement. But there are clauses and such that protect privacy, assure confidentiality, and assure access and sharing of data, as well as security.
Thank you again for joining us today. I would like to thank the CDC for sponsoring this webinar. Please fill out an evaluation at the conclusion of today's webinar. This evaluation will provide us with useful information for our future programs. And please be on the lookout for a link to our recordings for all 3 webinars in the Prevention Research Center's webinar series. Thank you, and enjoy the rest of your day.